Hello, and welcome to the Appropriate Use Criteria Explained webcast. I'm Mary Beth Farrell, the Director of Accreditation for Nuclear Medicine and PET. During this webcast, I will be explaining several tools currently available to help facilities measure appropriate use. There are two other webcasts in this series providing more detailed information. The first webcast explains tips and tools available, and the second webcast explains the ICANL accreditation requirements for incorporating appropriate use criteria into clinical practice. Most people are aware that there has been a dramatic increase in cardiovascular imaging, to be specific, cardiac radionuclide imaging, over the past decade. This has led to a corresponding increase in scrutiny from health plans questioning the necessity of these tests. And while there can be no doubt diagnostic imaging provides many benefits to patients and is critical in the delivery of quality health care, the cost ramifications associated with this increased imaging must be acknowledged. Numerous insurance payers have devised methods of utilization management with the aim of decreasing the volume of studies performed and thus driving down costs. Examples of such methods include prior authorization, pre-notification, denial of claims, and the increased involvement of radiology benefits management companies. None of these employed methods, however, are founded on quality. In response to efforts by insurance payers to limit imaging studies, the American College of Cardiology Foundation, or the ACCF, in conjunction with other professional societies, developed appropriate use criteria for the most commonly performed cardiovascular imaging studies. The main objective of the criteria is to identify patients who will most appropriately benefit from the procedure and thus result in more effective and equitable allocation of healthcare resources. Appropriate use criteria have been developed for radionuclide imaging, cardiac computed tomography, magnetic resonance, and echocardiography. Ensuring the right patient receives the right test at the right time is the ultimate goal. The decision of when and how often to do an imaging study is based on three factors. 1, scientific data. 2, the patient's clinical condition. And 3, the physician's judgment. It is expected that the appropriate use criteria will help to minimize inappropriate utilization, increase utilization in specific at-risk populations such as diabetics or patients with heart failure, improve image quality, and facilitate reimbursement. And although the criteria are intended to provide guidance in decision-making, they are not intended to replace sound clinical judgment and practice experience. The inaugural set of appropriate use criteria for single photon emission computed tomography, myocardial fusion imaging, were published in 2005 by the ACCF and the American Society of Nuclear Cardiology. Out of 52 clinical scenarios, 27 were rated appropriate, 12 were rated uncertain, and 13 were rated as inappropriate. In 2009, the appropriate use criteria were refined for radionuclide imaging, including cardiac positron emission tomography, and published again, but this time with the involvement and the endorsement of many more additional professional societies. The appropriate use criteria help guide physician decision-making by providing objective, evidence-based guidance regarding the use of cardiovascular imaging in the most common clinical scenarios. Although not intended to be entirely comprehensive, the indications are meant to identify common scenarios encompassing the majority of contemporary practice. One of the most important steps in developing the appropriate use criteria was agreement on the definition. The definition had to consider specific test performance characteristics for a specific clinical indication, the possible negative consequences of imaging, the impact of cost, and realization of how the test results might lead to care and could improve the patient's chances for better survival or improved health status. With these considerations in mind, the following definition of appropriate cardiovascular imaging was used. An appropriate imaging study is one in which the expected incremental information combined with clinical judgment exceeds the expected negative consequences by a sufficiently wide margin for a specific indication that the procedure is generally considered acceptable care and a reasonable approach for the indication. Put another way, the goal is to determine whether, based on scientific evidence, an experienced physician in a specific clinical situation would conclude that performing the imaging study is reasonable when providing quality clinical care. The appropriateness criteria are divided up into three separate categories: Indications are scored from 9 to 1, with 9 being the most appropriate and 1 the least. Ratings of 7 to 9 indicate the use of radionuclide imaging, which is appropriate, generally acceptable, and a reasonable approach. Scenarios rated from 4 to 6 were considered neither appropriate nor inappropriate, but uncertain for a specific indication. Ratings from 1 to 3 signify a radionuclide imaging study which is inappropriate for that indication and generally not acceptable or a reasonable approach. In 2009, appropriate use criteria comprised 67 clinical indications, 33 of which were appropriate, 9 uncertain, and 25 inappropriate. New indications were added to the 2009 criteria for heart failure, atrial fibrillation, ventricular tachycardia, syncope with high coronary heart disease risk, and selected elevated troponins. Here are some examples of indications that are clearly appropriate reasons to perform myocardial perfusion imaging. A patient having chest pains with a high pretest probability of having coronary artery disease whose ECG is uninterpretable or who is unable to exercise. A patient with worsening symptoms who is known to have coronary artery disease from a previous cardiac cath or myocardial perfusion scan, or evaluation of left ventricular function in a patient with a non-diagnostic echocardiogram or a symptomatic patient with a history of coronary artery disease and new onset of diagnosed heart failure. These are examples of inappropriate indications. A patient who doesn't have any symptoms and who is at low risk to develop coronary artery disease or a scan for screening reasons. A patient without symptoms who is going to have a low-risk surgery such as an endoscopic procedure. A patient with coronary artery calcium score less than 100, or finally a patient who is not having symptoms and is less than 1 year since coronary revascularization is considered to have an inappropriate indication. This implies that routine scans in asymptomatic patients following revascularization is not appropriate. In these examples of indications, the indications are rated as uncertain. That means there's not enough data to firmly establish whether the indication is appropriate or inappropriate. A patient who is not having symptoms with an intermediate coronary heart disease risk whose ECG is uninterpretable would be considered as an uncertain diagnosis or indication. Or a patient who is at low risk for coronary heart disease and does not have any symptoms but has new onset of atrial fibrillation would also be considered uncertain. It is important to stress that an uncertain designation for an indication means that there is not sufficient evidence or experience with the imaging study or detailed patient characteristics for the indication to definitively be categories. It does not mean that the imaging test should not be performed in that particular situation and that there's no evidence of benefit. The 2009 criteria are sorted into 8 tables. The indications are categorized based on the detection of coronary artery disease in symptomatic patients, detection of coronary artery disease in asymptomatic patients, risk assessment, assessment of viability, and evaluation of left ventricular function. The tables are presented two ways. The first way, the tables are organized by the categories I just mentioned. In the second way, the tables are categorized by appropriate, inappropriate, and uncertain indications. These logical groups of similar indications make it easy to apply the criteria to real patient scenarios. To facilitate use of the criteria, a hierarchy of potential test ordering was created. An algorithm points users to the correct table based on the patient's clinical presentation. Appropriateness of the indication can easily be determined by answering yes or no to 6 simple questions, going to the applicable table, and then selecting an indication based on the patient's pertinent medical condition. The first question in the algorithm is whether or not the patient is being studied as part of the preoperative assessment. The appropriateness determination for preoperative imaging follows the ACC/AHA 2007 perioperative guidelines. If the patient is being studied for preoperative assessment, the indications in Table 4 are applicable. Surgical risk, clinical risk factors, functional capacity, and patient symptoms are also considered in further narrowing down to the correct indication. If the patient is not for preoperative assessment, the next question to be answered is whether the patient is within 3 months of an acute coronary syndrome. If the patient is within 3 months of acute coronary syndrome, Table 5 is considered along with the patient's symptoms and whether the patient had a prior coronary angiogram or are used to determine indication. If the patient is not within 3 months of an acute coronary syndrome but is being evaluated after angioplasty or coronary artery bypass, clinical indication is determined by evaluating Table 6. The patient's symptoms, success of revascularization, and the time of the last test are used to determine the indication. Radionuclide imaging is appropriate when the patient has new symptoms following revascularization. However, if there are no new symptoms, imaging appropriateness depends on the interval since the angioplasty or the bypass surgery. The next question to be considered is whether or not the patient has undergone prior testing, such as an exercise stress test, imaging, coronary angiogram, or coronary calcium score. The type of prior testing, length of time since testing, and whether the patient is symptomatic are considered in Table 3. The criteria suggests that it is inappropriate to repeat stress imaging within 2 years unless the patient has had new or worsening symptoms. The final question in the algorithm relates to whether the patient has symptoms. If the patient has an ischemic equivalent, then Table 1 is used to determine appropriateness. Key in the evaluation of symptomatic patients is the patient's pretest probability of coronary artery disease, ability to exercise, and ECG interpretability. If the patient is asymptomatic, Table 2 is used. And in order to determine appropriateness in an asymptomatic patient, the patient's coronary heart disease risk using the Framingham risk score and interpretability of the ECG must be considered. In addition, other factors such as if the patient has heart failure, syncope, atrial fibrillation, or ventricular tachycardia are important, and radionuclide imaging may be justified. Of the remaining 2 tables, Table 7 only has one clinical indication and is used for the assessment of viability in patients eligible for revascularization with severe left ventricular dysfunction. Table 8 is used in the evaluation of left ventricular function by equilibrium or first-pass radionuclide angiography. There are many definitions and processes within the criteria with which technologists must be familiar in order to correctly apply the criteria to a given clinical scenario. These include ischemic equivalent, coronary heart disease risk, anginal classification, pretest probability of coronary heart disease for symptomatic patients, acute coronary syndrome, and perioperative risk. I'll describe each of these terms in detail. So our first term is ischemic equivalent. An ischemic equivalent is such that chest pain syndrome, anginal equivalent, or ischemic ECG abnormalities refers to any clinical findings the physician believes is consistent with obstructive coronary artery disease. Chest pain, chest tightness, burning, shoulder pain, palpitations, jaw pain, new ECG abnormalities, shortness of breath, or worsening of exercise tolerance are examples of patient descriptors of ischemic equivalent. Coronary heart disease risk is classified into 3 levels of risk, with absolute risk defined as the probability of developing coronary heart disease, including myocardial infarction or coronary heart disease death over a given period of time. Essentially, it's the risk of a hard cardiac event, myocardial infarction or cardiac death, based on the Framingham risk variables of gender, age, total cholesterol, HDL cholesterol, smoking status, and systolic blood pressure. There are numerous easy-to-use tools available on the Internet for calculating the Framingham risk score. There are 3 levels of coronary heart disease risk. Low coronary heart disease risk is risk that is below average level and correlates with a 10-year absolute coronary heart disease risk that is less than 10%. Moderate coronary heart disease risk is risk that is average or above average and correlates with a 10-year absolute coronary heart disease risk that is between 10 and 20%. And high coronary heart disease risk is defined as the presence of diabetes in a patient 40 years or older, peripheral artery disease, or other coronary heart risk equivalents, or a 10-year absolute coronary heart disease risk of greater than 20%. Angina is precisely defined in the appropriate use criteria. Angina is described as typical or definite, atypical or probable, and non-anginal. Typical angina, or definite angina, is substernal chest pain or discomfort provoked by exertion or emotional stress and relieved by rest and or nitroglycerin. Atypical, or probable angina, Is chest pain or discomfort lacking one of the characteristics of typical angina? And finally, non-anginal chest pain is chest pain or discomfort meaning one or none of the typical angina characteristics. Pretest probability of coronary artery disease for symptomatic patients can be determined by several methods. The method assumed for the appropriate use criteria is the ACC-AHA 2002 Guideline Update for Exercise Testing and the ACC-AHA 2002 Guideline Update for Management of Patients with Chronic Stable Angina. Using the previously listed definitions of angina and the table on the next slide, the pretest probability of coronary artery disease can be easily determined. A high pretest probability equates to greater than 90% likelihood of having coronary artery disease. An intermediate pretest probability has between 10 and 90% likelihood of having coronary artery disease. A low pretest probability has between 5 and 10% likelihood of having coronary artery disease, and a very low pretest probability has less than a 5% likelihood of having coronary artery disease. So I just mentioned pretest probability can be determined by knowing the patient's age, gender, and type of angina. For example, if you look at the chart, a 43-year-old male with typical angina, such as chest pain that is caused by exertion and relieved by nitroglycerin, would be considered to have a high pretest probability of coronary artery disease. Another term that technologists need to be familiar is acute coronary syndrome. Acute coronary syndrome is defined as unstable angina, myocardial infarction without ST elevation, or myocardial infarction with ST elevation. Once it is determined that the patient does not require urgent surgery and there has not been revascularization within the last 5 years, the physician can determine the patient's preoperative risk predictors. If major risk predictors are present, coronary angiography and the postponement or cancellation of non-cardiac surgery might be considered. Major risk predictors include unstable coronary syndromes, decompensated heart failure, significant arrhythmias, and severe valve disease. Intermediate risk predictors include mild angina, prior myocardial infarction, compensated or prior heart failure, diabetes, and renal insufficiency. And minor risk predictors include advanced age, abnormal ECG, rhythm other than sinus on the ECG, low functional capacity, history of cardiovascular accident or stroke, and uncontrolled hypertension. And then the last definition to use the appropriate use criteria is the surgical risk categories. Once the perioperative risk predictors are assessed that I just discussed, then the surgical risk from this chart and the patient's functional status is used to establish the need for non-invasive testing. High-risk surgery, such as emergency surgery or aortic or peripheral vascular surgery, can carry a risk of cardiac death or myocardial infarction of greater than 5%. Intermediate risk surgery, such as carotid endarterectomy or prostate surgery, have a 1% risk of cardiac death or myocardial infarction. And low-risk surgery, such as endoscopic procedures or cataract surgery, have a less than 1% risk of cardiac death or myocardial infarction. So now that I've explained the appropriateness criteria and defined most of the terms, let's try them out with a real-world example. A 50-year-old man is referred to your facility for myocardial perfusion imaging. The patient had chest tightness and dyspnea while shoveling snow this winter. He has no other medical conditions. The patient has mild hypertension and mildly elevated cholesterol and smokes cigars. Would myocardial perfusion imaging be appropriate or inappropriate or uncertain for this patient? The first step is determining appropriate is to use the hierarchy of potential test ordering. Our patient is not pre-op. He has not had a heart attack or other acute coronary syndrome in the past 3 months. He has not had previous angioplasty, stent, or bypass surgery, and he has not had previous imaging, but he does have an ischemic equivalent. The next step is to determine the type of chest pain our patient had. Our patient had chest pain with exertion that went away with rest, so he has typical or definite angina. Then using the pretest probability table I mentioned before, you can determine that a 50-year-old man with typical angina has a high pretest probability of coronary artery disease. Taking all of that information and using Table 1 as directed by the algorithm, myocardial perfusion imaging in a patient with a high pretest probability is appropriate. Incorporating the measurement of appropriateness criteria into clinical practice allows physicians to assess current practice patterns and identify areas of improvement. A review of literature published since 2005, when the first appropriate use criteria were published, consistently demonstrates that approximately 10 to 14% of all studies performed are performed for inappropriate indications. A recently published pilot study done by the ACCF in conjunction with United Healthcare used the 2005 appropriateness criteria to evaluate almost 6,000 patients at multiple practice sites. The results of this study demonstrated an overall inappropriate rate of 14%. The study further examined the specific inappropriate indications and their percent of the overall total studies. It was noted that only 5 indications comprised over 92% of inappropriate imaging. The most frequent inappropriate indication, encompassing 44.5% of the inappropriate indications, was for the detection of coronary artery disease in asymptomatic patients with low coronary heart disease risk. This represents 6% of the overall total studies. A facility that focused on just decreasing studies performed for this indication could significantly reduce the number of inappropriate studies performed. With a little knowledge, figuring out how to use the appropriate use criteria is easy. The criteria become more and more widely accepted in the healthcare arena and will hopefully begin to play an increasingly prominent role in utilization management. Moving forward, healthcare professionals must take responsibility for the imaging studies performed at their facility. While quality imaging is extremely important, studies must also be appropriate, or it's likely that payers will not continue to reimburse for them. As a field, we must come up with methods to assess and document levels of appropriateness in practice in order to continue providing quality health care. In closing, I hope you have a better understanding of the appropriate use criteria and will now find them easy to use. There are several tools available to help you measure and track appropriate use in your facility. These tools can be found on our website at www.icanl.org. Please feel free to contact me, Mary Beth Farrell, Tom Roy, the Associate Technical Manager, or any of the ICANL staff at any time with questions. We look forward to working with your laboratory in the accreditation process.